the one elephant in the room that we never talk about. We all talk about social determinants of health contributing towards cardiovascular disease. And there are 4 or 5 things in social determinant, but I have one simple word for that. It's called poverty.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This is episode 76. And, this is going to be an episode which is very close to my heart, because of how I think about South Asian heart health and how I've invested a mission in making a difference in the lives of, millions, if not billions of South Asians who suffer with the scourge of coronary disease, and the burden is immense. And I could not be happier to have this guest on the show who actually is walking the talk. He's not only talking the talk, but he's walking the talk. And we were just talking off the line before we started recording, and I'm sure we're going to delve more into this. So my guest on today's show is Dr. Sohail Khan. He's an interventional cardiologist and an endovascular interventionalist, who was born and bred in Pakistan before he actually moved to the US for further training after finishing his medical school from Aga Khan University, which I'm sure the audience is well aware is one of the premier medical institutions in Pakistan, but has campuses worldwide. And then, has been a very successful interventionist in the US, and gave all that up to move back to Pakistan last year to sort of pursue his mission of touching and affecting lives of his own countrymen, but more importantly, South Asians and the heart health in South Asians. And the burden is so immense in this population that I think his services and his skills are going to be are going to be meaningful and impactful in a much bigger scale, in a much larger scale. So with that introduction, Dr. Sohail Khan actually is the Chief Operating Officer of the National Institute of Cardiovascular Disease in Karāchi in Pakistan. And I'm sure he's going to talk more about it. So, but with that introduction, Sohail, welcome on the show, and thank you so much for doing this for us.
Thank you, Ankur, for inviting me. I'm very excited to join you here today.
So Sohail, let me start this conversation by asking you, first off, and I did briefly introduce you on the show, but it's best if it comes from you than from me. Tell us a little bit more about your upbringing, in Quetta in Pakistan before you went to medical school and then decided to come to the US for further training and clinical practice.
Sure, Ankur. So I grew up in Quetta. I was born and raised in Quetta, which is it's kind of not very well established city in a province of Balochistan. It's a 2 hours drive from Afghanistan. It's a mountainous region. Grew up there, and then for my middle high school, went to military school for 5 years, and then, as you said, to the Aga Khan University. Graduated in 2003. And then went on to do training in the U.S., my medicine, cardiology, interventional, then trained further in endovascular intervention, different institutes. I was a high-volume operator in endovascular intervention till 2021 when I moved back to Pakistan. And also used to run one of the largest endovascular meeting in the Mountain West region in Salt Lake City. Did that for a couple of years. I was the chairman of that meeting. And then in 2018, I decided to do master's in healthcare management from Harvard University. Always wanted to get into the business side of medicine. and always had this goal of building a hospital in Quetta, which is my hometown, very underserved when it comes to healthcare facilities. Most of the patients, they end up driving 600 miles to Karachi to get a better care. So that was always my goal, to give back and establish that hospital. And for that reason, moved back a year ago in 2021. While I'm working on that hospital, which should be operational in next 6 months in Quetta, about 250 bed hospital, I decided to avoid a private practice, cardiology in Pakistan, where, of course, you'll make good money. But I decided to join a public hospital, which is NICVD, which I think is the busiest cardiac network in the world. Most of the care is free for patients, for poor patients. So that's when I decided to join this facility to help the poor population. And then recently, a couple of weeks ago, I was also appointed as a chief operating officer for this institute. So this is where I am. I am the chief operating officer of this institute, which has its own challenges that we'll talk about later. But at the same time, I have this family project that I'm doing in Quetta, which is my hometown. So as you can see, I'm wearing so many hats. So yeah, that's that.
Yeah, no, it's incredible background, very interesting, and uh, congratulations for making, as I call it, the bridge back to the east from the west. It's a hard decision for many of us. I've sort of been in this boat for um, I would say over the past couple of years, deciding whether to stay back on or move back to the east to sort of be of impact and be of service to our own people there. So congratulations for making that decision. Do you want to go over that decision with us, with the audience? I'm sure there will be a lot who will actually resonate with what you have to share and say.
Ankur, as you said, it is one of the most difficult decisions I've ever made. I have three kids. They're all American. They're born there. I've been in the U.S. for since 2003, 2004, so many years. And I can tell you, I'm totally Americanized. I just love America. I am who I am because of that country, and used to love my practice and everything. Um, but there came a point in life that you check all the boxes. Now you're a cardiologist, you're making good money, you have a reputation, uh, you know but then you get into this rat race of RVU chasing, especially the way the healthcare is going, and in the US, especially the commercial side of things, the insurance side of things, the corporate side of things, the physician losing that autonomy and that satisfaction, and that's what I was lacking in my life, and that meaning in my life. You want to be somewhere where you can make an impact. And as a cardiologist, U.S. Has achieved a lot in the sense of the quality care. I mean, there's still a lot of things to improve, but being as a physician, what other impact you can make? You can make that impact more in a country like India, Pakistan, where cardiovascular is, this is so abundant here. So that was one factor for my own, I was going through that self-realization process, finding that meaning in life. Always wanted to build this hospital in Quetta, but again, moving from US to doing that, it's challenging. But the thing is, there are certain things that happens in your life. I mean, the biggest teacher in your life is your life experiences, and one of my very close friend, last year, super nice guy, one of the smartest guy that I know. He was a physician, and he committed suicide, and I was involved in all of his last rituals, and taking care of his body, his bank accounts, hiring a lawyer, and then moving his body back to Pakistan, and because his family was not there in the U.S. When he died, I still remember. It still kind of makes me mad. The hospital removed his name from their website within 12 hours. And I'm like, is this who we are? Is this, what our worth is as like physicians? Like, for example, you die and within 12 hours you are gone. You're not even part of that hospital. It's kind of kept me thinking about overall about life. I mean, what is the meaning of life? What if Sohail Khan dies today? I mean, in 2-3 days, people will forget about me and the life would move on. So that kind of woke me up as a person, and I just decided, if life is so short, unpredictable, why not do something for others? Why not, whatever I always thought about doing in my life, why don't I just, take that leap and do it, and that incident really made my decision easy, and then I talked to my wife and we moved back, and that's my decision of joining this public hospital which caters to poor population. That was a part of it too. But then also building this hospital in Quetta, because again, my goal is not just to build another hospital and business. I want to change the healthcare paradigm. So when you know your mission, your goal, your North Star, that make life, worthwhile. That brings that meaning in your life. Again, this is a long answer, but I'm just giving you the whole background. Going back to your point, moving back is not easy, but you have to have a very good reason and mission and goal. That makes it bearable, I think.
Oh, yes. No, I mean, and thank you for the long-winded answer. I think the reason for me to ask this question was precisely for you to delve into the deeper aspects of why certain decisions are so important and come from an internal compass. You mentioned North Star, and I think each one of us has its own North Star. And the internal compass needs to be in balance. If internally you feel out of balance because of could be anything that is so central to your existential being, then I think it is your obligation and responsibility to listen to that internal compass. And I think each one of us has, as you mentioned, life experience and life changing events and life altering occurrences, which I do think really shake us and really challenge that internal compass. And once you reach that point, I think it's important to be with yourself, important to go out in the nature, important to ask yourself the hard questions like you did. And then once you have answered those questions for yourself, more importantly than anyone else, just completely tuning out the external noise and listening deeply to your inner voice is what will guide you. So, I congratulate you for going through that exercise and making that vital decision. I'm sure wherever you are going to impact lives. And, like I said in the introduction, it could not have chosen a better topography or a better geographic location for being the most impactful by utilizing your skills and your knowledge and all the training, all the exceptional training and experiences that you've garnered in the West to then impact people in the East who both, you and I know, the burden of atherosclerotic vascular disease. I sort of have this conversation with colleagues in the West that, in terms of the footprint on the globe, South Asians, I think comprise 20%, but they harbor 30% of the atherosclerotic vascular disease burden globally. So I think in terms of the impact you will make by working for institutions like the NICVD and also your own institution in Quetta, I think is enormous. So congratulations for that. So now, just focusing the conversation to NICVD and some of the work that the organization is doing. Do you want to describe that to the listenership and to the audience, who may not be familiar with the footprint of the organization in the Sindh province, right, in Pakistan?
Yes, Sindh province. So yeah, we have 4 provinces or state in Pakistan. So Sindh is one of them. It's one of the oldest civilizations in the world, going all the way for 5,000. So yes, so this NICVD, it was a standalone hospital which was built in 1960s. It's a government-run hospital, publicly subsidized through taxpayer money. Then it underwent transformational change back in 2016, where from one center, the government decided to open smaller satellite hospitals throughout the province of Sindh. So now we have one main hospital in Karachi, which is the NICVD, and then 9 satellite centers in different smaller cities throughout the state of Sindh. And it is a tertiary cardiac hospital. So, I mean, we have emergency room, we have critical care, we do dialysis. So anything pertaining to cardiology and its complication, we take care of that. And it's a very high volume center. And that is something that I don't want to, we should not take pride in it, because that means there's something wrong here. There's a tons of heart disease. And to be very honest, I came here as an interventional cardiologist last year in August, and now I've become more of like preventive cardiologist. There's so much disease in the US. In any busy center, for example, I remember if you get 2-3 STEMIs a day, it's a very busy day. Here we get on average about 30 to 35 STEMIs every day. And I'm talking about just NICVD Karachi. I'm not talking about 9 other satellite centers. So this is how big it is. But the best part I like about it is most care is free. I mean, if you come in the middle of the night at 2 o'clock, no one is going to ask you about insurance or whether you have money in your pocket. In Pakistan, there's very limited insurance program. Most of the care is out of pocket. So that's the beauty about working here, is that even if I get some rickshaw driver or some bus driver, we never ask them about money. I mean, if they have heart attack, the primary angioplasty is done, the drug-eluting stent, the Medtronic drug-eluting stent is implanted. And that is what is very satisfying, and that is what is very impactful here.
Yes, I mean, in terms of the way you describe it, and public hospitals in India would work in a very similar fashion. These are federally funded, as you may call it, here in the U.S. And care. Personally, I have not worked at the Veterans Administration medical centers, but very similarly, care is the only focus. And like you said, you do not have to worry about payers and insurance and reimbursements and pre-authorizations. You just go in and you've been trained to be a cardiologist and be of help and service to patients, and that's what you do. And that's very satisfying. And so what you describe is very similar to, public hospitals in India. And if I may extrapolate that to the NHS, in the UK. And the volume of acute coronary syndromes that you described, I agree. Again, I mean, I think you go to any busy public hospital in India, and I think you'll hear of similar volumes. And that becomes a challenge if you want to then accrue data and sort of look at the outcomes and whether it's outcomes at 1 year or whether it's longitudinal follow-up. The burden of disease is so much, and clinicians are so busy taking care of patients. And there are the ratio between clinicians and patients is completely off balance, that it becomes very, very hard to actually put the data together and analyze it. What do you have to say about that? And I think having had the experience in the West how do you envision to sort of maybe change that? And I know that you're working with Dr. Virani, who's been a long-time mentor of mine. But if you want to sort of delve into this, that'll be of interest to the audience.
Yeah, sure. I mean, as you said about the volume, yes, the volume is here. Among all our NICVD and the satellite units or hospitals, we do about 18,000 primary PCIs a year, more than 4 to 5,000 open heart surgeries. But the thing is there a quality there? So that's a big question. And I don't think so. We do a very good job, but there's still a lot of things that can be improved. Like, for example, Kat, we are part of NCDR, but I'm not satisfied the way the data is put there. So that's something we need to improve here. And if you look at our OPD and emergency volumes, about twice, it is 2-to-1 ratio, like most patients, they present to the emergency room than the OPD. So what that means is that they come to the emergency room only if they're having a heart attack or if it is an emergency, but there's a lack of follow-up. There's a lack of preventive cardiology here, or lack of focus on good hypertension treatment, hyperlipidemia treatment. So this is another pattern that I'm seeing. But I have some plans for it. As you know, we have another model called a chest pain unit model, and we can talk in detail about that later. But that is something where we can incorporate those chest pain unit instead of just using them for an emergency. We can also start doing some screening clinics. So again, there's another thing is lack of awareness of heart disease. And then the one elephant in the room that we never talk about, we all talk about social determinants of health contributing towards cardiovascular disease. And there are 4 or 5 things in social determinant, but I have one simple word for that. It's called poverty. That is huge here. I mean, that poverty leads to a lot of issues, lack of access, affordability, and awareness. How do we handle that? That is a big challenge, especially in a country like Pakistan, which is struggling in terms of economy. So there are so many layers to it. We are doing a great job, but there's so many things that can be improved.
Yeah, no, I mean, absolutely. Like I said, I think the delta of the impact that you are going to make, just having someone with the kind of exposure that you've had and the kind of experience working in the US that you've had, and knowing how quality is sort of completely inbred in the system and it's sort of the way you think as you do things. I think just having that cognitive skill set back home, in Pakistan for you, and sort of just disseminating that amongst practicing colleagues and physicians is, that alone is going to be so impactful.
So, just to add to yours, so I do some talks on hypertension pretty much every month. Again, I'm becoming more preventive cardiologist than interventional. So we had a meeting a couple of days ago. There were about 10 senior physicians from across the city on hypertension management. When it comes to guideline, only 3 out of 10 were like really following the guidelines. So this education is not in countries like Pakistan. Somehow, if being older or having gray hair is associated more with ability than having the real ability. So convincing someone who is a professor somewhere and he tells you and that this is so-called my experience, this is how I've done in last 30 years. That is another challenge too in countries like Pakistan or India. Forget about patients. How do you convince primary care physician to change their, the way they treat patients? That is another challenge that I'm facing, but I'm working on it. You have to be consistent with your message, with your efforts for awareness. And you just talked about Dr. Salim Virani. Actually, again, small things matter. Like, for example, just being a South Asian, we have a lot of things in common, our love for food and cricket and whatnot. The other thing very common among us is we are also one of the risk factor for CAD per ACC guideline. And that's one thing that I noticed when I came back to Pakistan and I saw the sheer volume of heart disease. I mean, what else is going on? So the one study that I'm doing is on lipoprotein A. I mean, that is something we have never looked at, in this rich cohort that we have in Pakistan. There are like studies in UK and US where they have looked at South Asians. But I'm really excited to do that study here in Pakistan, looking at lipoprotein here, especially in younger people. And, what is the association? What else is going on that is different in the US and UK? So, I mean, there are so many things that I want to find those answers. So, yeah, that is something I'm really, really excited about.
Yes, no, I mean, again, Salim Virani is very important, is a very important person in my life. And I say that because one of the first papers that we both wrote together for the work we actually did in India for the ACC, and this is the extrapolation of the Pinnacle registry you mentioned, NCDR. So Pinnacle is one of the outpatient NCDR registries, as you know, and this was an extrapolation of Pinnacle to India. So it was the Pinnacle India Quality Improvement Program. And, we still talk about this, but, one of the very first papers exploring the intersection of South Asian heart health and the work that ACC was doing in India. And that's how I got involved, and came to know about Dr. Virani was when we did this paper together. And, ever since we've been in close contact and communication, and I still look up to him as someone I can just pick up the phone and call whenever I am in search for answers that my soul is asking. So we've that kind of relationship. And again, I think as interventionalists, we should be the torchbearers of prevention, because we just see it so much, prima facie in the lab, that, it sort of should be impetus enough for us to be the torchbearers of prevention. And again, I think the lives that you'll impact by disseminating some of the important knowledge base about prevention is going to be key. And who better than Salim Virani to talk about Lp(a) and sort of establish a trial to answer that question. Do you want to talk to us about that trial that you're planning on Lp(a) in Pakistan?
Yes. So one of the biggest issue in Pakistan is that once you treat a patient with ST elevation MI, the follow up is terrible. About more than half of patients, they don't follow up with you in the clinic. So what we wanted to do is that we wanted to do a study where we look at patients who are coming in with acute MIs, and then drawing the lipoprotein A on those patients, as you know that the acute MI or someone on statin therapy does not really affect the level of Lpa. So this would be a cross-sectional study for now. We will have 3 groups. In one group, we'll have patients who are less than 40 years age with acute MI. The second group will be age more than 40, and the third group will be control. And then based on this study, our next plan is going towards the therapeutic part of the study, which will be in the second phase. We have been approached by a certain PCSK9 inhibitor company to kind of run that sort of a trial. But in this current trial, which is it's more like a study, cross-sectional study, we will enroll about 1,000 patients. And you'll be surprised to know that we didn't have that Lpa assay here in Pakistan. No one checks for it, so we have to get that from Germany. And I had to convince Abbott to provide that assay for free. So thanks to Abbott for doing that. So this is the gist of it. Again, all we know about LPA is like studies from UK or US, where they look at one of the sub-study looking at the South Asian, but this will be a true South Asian population that we will be looking at. And I'm convinced that the disease burden in South Asia, those South Asian living in South Asia, is higher than South Asians living in UK and US. There might be some other environmental factors, like poverty and whatnot. But this is what I think, and this study will provide us that info.
Oh yes, and again, yeah. So the one thing, the one thing you mentioned here um, is designing and conducting a trial um, for South Asians in South Asia, which I think you sort of just hit the nail on its head there, because here we are in the West, and obviously we have um, the luxury of the high fidelity data that we have from randomized clinical trials, and Salim Yusuf actually in Canada has done some of the important and seminal work in South Asians. But again, these are uh, uh, prevention trials, and these are trials which are mostly epidemiological. I mean, these are epidemiological data and also prevention trials. So the data garnered are certainly important, but I've always longed for designing and conducting a study, which, for example, a drug trial. Like, how many trials do for some of the antiplatelet therapies or some of the direct oral anticoagulants that we use so regularly in South Asians? I mean, you just write the prescription and all these drugs are available, but you then sort of pull the paper and look at the trials where these trials were done and conducted. And, a lot of these trials were just conducted out in the West, and the inclusion criteria were, Caucasians or Westerners. And we sort of just blindly extrapolate the findings and the results of these trials, and we prescribe these drugs in our patient population in South Asia. So the fact that you're conducting a randomized clinical trial for South Asians in South Asia, that is exactly what we need. So we need more people like you doing the kind of work that you're doing, because that's the only way to garner data on South Asians, and that's the only way we're going to learn, novel information impacting the health for those patients. So congratulations, and again, I'm just living vicariously through you, because that's the kind of work that I want to be involved with, and that's the kind of work that I want to do.
And just FYI, and I'm also talking to Samir Gupta. He was also trained in the U.S. Now he's practicing in New Delhi, and then Asha Kadir. She is in Bangladesh, Dhaka, Bangladesh. So I'm going to share the study protocol with them as well, and they can run the similar studies, and we may be able to do some pool analysis at the end of our little trial here. So again, we need our own local data, not only from Pakistan but also India and Bangladesh, and that is what represents true South Asia.
Oh no, congratulations, and I do know both Aisha and Samir really well. Samir, actually, I recently had a phone call, maybe less than a couple of weeks ago, and Aisha is going to be a prospective guest on Parallax as well, just as you. But no, congratulations, and it's not a surprise that the three of you are interventionalists, and
we did a webinar actually a month, 2 months ago. I can share the link with you, and we did a preventive cardiology webinar, with all three interventionalists, and Salim Virani was there. Dr. Khurram Nasir from Houston Methodist was there as well. He's also one of the champion in preventive cardiology. So I can share the link with you and your audience as well for that webinar.
Yeah, no, please do. We'll actually post that link in the show notes for this episode. But again, these are names that resonate with me really well. I all know them in person, and incredible group of people that you've garnered, and more power to you, and more success to you, and more soul searching to you, because when you do that, what manifests is the work that you're doing with Lpa and the work with NICVD and your own, new hospital in Quetta. So any closing remarks, Sohail, anything that you think we should have talked about or discussed, which we haven't, then we should. This is sort of the final few minutes of the podcast.
It's just I wanted to talk about the other thing we do at NICVD is a unique model called the chest pain unit model. So we have these about 21 chest pain units, 17 of them are in Karachi, and basically they are small containers where the patient comes in. If they're having chest pain, we do the ECG there. If they're diagnosed with ST elevation, we give them anticoagulant, aspirin. We have a defibrillator as well. If they need to be intubated, we can intubate them, and then they are shipped to primary PCI programs. And this is a great model for a city like Karachi with 20 to 25 million people, very dense traffic. There are a lot of delays, and also cities like Mumbai, Sao Paulo, Dhaka. So actually, I'm writing a paper on it, in the process of compiling all the data. And this is such a unique model that can be applied to any major city in the world. So that's one thing, I just talked about briefly, and I'll be sharing that data with you very soon, and we can, you and I can write both on that, and then if you're asking me about my, remarks at the end, I would say is that, we can all learn how to put stent, but, the most important as we grow, the most important things in life is again, as we said earlier, having that self-realization, learning the soft skills in life, learning the empathy part, the servitude, just knowing that, that life is short and unpredictable. We should stay focused on happiness. We should stay focused on having some mission in life. And then, just live happily, be helpful to others. And that's what we should all learn and aspire to. Yeah.
Yeah, no, just all excellent points. And, thank you actually for bringing up the chest pain unit. You shared the very informative and actually awe-inspiring video on Twitter, as well as other social media platforms that you're active on. And, I was just in awe with the innovation with chest pain units, and also where these units are placed in the city, a city as busy as Karachi, but, no reason why, this model cannot be, implemented in busy cities like Mumbai and Delhi. And you mentioned about delays. I mean, you can have the most skilled interventionalist, you can have the most well-equipped cath lab, you can have the transportation available, but if you aren't just able to get to the hospital, then you're losing time. And both you and I know, I mean, having worked as interventionalists, that time is muscle.
And then just imagine how low cost it is. You don't have to build up the structure, right? You don't have to pay the rent. It's just a container, right? And the other thing that I'm working on right now, I'm in the process of trying to digitize all 17 chest pain unit, where there's a good data integration, where we can also run some screening clinics here. I mean, if we have the infrastructure, the doctor is there on call, the staff is there on call, why can't we do like screening? I mean, if we have such a high cardiovascular disease burden there, we can check their cholesterol, we can screen them for hypertension. And I'm also in the, talking to different pharmaceutical companies that, why don't they help us in providing a low-cost medication to these patients? I mean, once the patient comes in, we screen them, they have hypertension or hyperlipidemia, they can give them medication for free for a couple of months, and after that, at low cost. So we have to create a win-win situation for everyone. I mean, the government is not here to, I mean, there is no margin, there is no mission. I mean, we should not depend on the government forever to provide us funds. We have to create a self-sustaining model. And this is what I'm thinking about. So again, that is another podcast. That's a whole different topic. But this is what I think that we should do here.
Yeah, no, absolutely. And thank you for offering to collaborate with you on the paper that you plan to write for the chest pain units. I'm all yours. If there's anything I can do to help in any way, shape, or form, just I'm literally a text away or an email away, and I'll be honored and delighted to be your co-author, and if I can in any way, shape, or form help, whether it's analysis or writing it up or with submission, just let me know. I'd be more than honored and happy to do so.
So, Ankur, you asked me about. Thanks for offering the help to write about this chest pain unit. And then my leaving remark is that as I said earlier, finding the true center in life is very important, and I also shared some very personal things with you, and I should commend you that you are very good at what you do, getting the deep feelings out of other people. And then about your book Ibadah, so I think you have that spiritual center that I can totally connect to. So again, thanks for what you do as well, and which is meeting people, interviewing people, inspiring people. And this is also I think very impactful, and this is of course your legacy as well, because these podcasts will stay online forever. So thank you so much for inviting me, and really looking forward to connecting with you and staying in touch with you.
Oh no, likewise. Thanks again for the very kind words. The reason I do this is I just feel a deep sense of mission. I feel that the corporate medicine in the US is lacking compassion and has lost its soul. That's what I truly feel. I think we need to, in part, I think the conflict of burnout, that's one of the central reasons why there is, just exponential burnout in the US. And I think, to your point, which was actually it was eye-opening as well as humbling, as well as it also invigorated angst, for lack of a better word, was how the hospital just removed, not even within 12 hours, the existence of that physician, who was part of the team, before he passed away. So, life is, like I said, is short. Life is fragile. And through these conversations and through connecting with like-minded individuals who ask these important and relevant questions and make decisions based on internal compass and have a mission-driven life, I think those are the people that I want to feature on the podcast, and with the hope that these conversations will inspire the audience who are listening, and we can build a community of like-minded physicians who are mission-driven. Because I think if I do genuinely personally believe that if your own life is mission-driven, then all these external forces can't really take that spirit of service out of you, which, as you know, can get lost in RVUJs. So no, thank you for the kind words, and again, to everyone who's listening, please rate us and review us, and I listen to all the feedback, and I read all the comments on social media as well as on Apple Podcasts and SoundCloud and Spotify. thanks for all the support. Because of all the support, we are now rated the second best podcast in cardiology by feedspot.com. These rankings just came out, within this past month. So thank you for all the support and these. The reason I even bring up rankings is that through this work, I'm sure we've been able to connect with physicians and with like-minded individuals, and it's through guests like Sohail and the work that they're doing that Parallax is what Parallax is. So thanks again, and we'll see you back other Monday with another guest like Dr. Khan. So thank you for your time.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.